thing is always any pulsatile lesion, do a Doppler. Don't stick a needle into it. Never ever you will biopsy a pulsatile lesion. Your patient will bleed to death the moment you give a needle biopsy here. You don't want to do that. CT angio may be done later on, but they're asking us the next investigation. Whenever they write best next, most appropriate next, it's the next investigation. Just think like a doctor. Don't get confused that, oh, should I go for best? Should I go for next? No, think like a doctor. What will you do next for this patient, right? Just keep it simple. I've seen so many students just getting confused for no reason in these investigation-based questions. Just keep it simple. If you are the doctor on duty, what will you just do next? Now, whether it is best next, most appropriate next, obviously you'll do the most appropriate investigation, right? Why would you not want to do an appropriate next investigation? So keep it simple. Doppler ultrasound. Smoker vein with painful ulcer. So there's gangrene. Any vasculitis in this person, when you have a smoker, what is your consideration? You want to rule out Berger's disease, right? Thromboangiitis obliterans. They are asking what is the best initial investigation. What is the best initial investigation for anything vascular? It is Doppler ultrasound. So remember, initial is ultrasound. Then they ask you best, CT angio, gold standard, DSA, right? So this becomes Doppler ultrasound. With this, we finish the first part, that is general radiology. Next, we move on to GI. So let's begin the discussion now of GI and hepatobiliary systems. The first thing that I'm going to talk about are the barium studies. So as we discussed, barium sulfate is the compound that we use here, and we are only going to give it either by oral route or as an enema. We will never give it as an IV contrast agent. Okay, so that's something which is very important, and they need to be within the GI tract. If it leaks out, they have their own risk of peritonitis, so we will never ever give it in a suspected case of perforation or intestinal obstruction. So now, how do we name the studies? The studies are named according to the part that you're going to be testing. If we are testing the esophagus, the study is called as barium swallow. So the barium swallow study is where you're going to evaluate the esophagus. Okay, so this is where the patient just drinks the barium and you take an X-ray to see the esophagus. If I want to evaluate the stomach, this is called as barium meal. So you can see here that the barium is within the stomach, and also the proximal duodenum can be evaluated here. So barium meal is for stomach and proximal duodenum. Now for the entire small intestine, what we do is barium meal follow through, what is referred to as BMFT. Barium meal follow through, where again the patient is going to drink the barium and now you're going to follow it for a while and see the small intestine. So barium meal follow through is for the small bowel. Now here you need to understand something. Look at this image. We need to know the parts of the small intestine. So what you can identify as a C loop is the duodenum. Now look at these loops here. You can see that they have a feathery contour, isn't it? So these loops are your jejunal loops. So the jejunal loops, remember, have this feathery outline. Why is this so? So this feathery outline of the jejunum is because of these folds. So now these jejunum, anatomically, we know have these folds which stretch across the lumen. These complete mucosal folds are what we call as valvulae coniventis. So remember, this valvulae coniventis is what is the hallmark of jejunum. Remember, this will also help us in intestinal obstruction. On the barium, it gives rise to this feathery contour, whereas our ileal loops, which are in the pelvis, more or less down in the pelvis, are going to be featureless. Imagine somebody's feature being that they are featureless. So that sad life is that of ileum. Okay, it has no loop, it has no folds. So that is what is the feature of ileum, right? So we have jejunum and we have ileum. Now, this is where the patient had taken the barium orally and we followed it into the small intestine. Compare that with this particular evaluation. My first question to you is, what do you think are these loops? So using the same concept, now you're going to see that, oh, now I see these folds so nicely. These are valvulae coniventis, isn't it? So this is what indeed are all of my jejunal loops. But aren't we seeing the distension much better than what we were seeing in our BMFT? We are. And the reason is I have put in a tube. So now I've put in a tube up to the DJ flexure, duodenal jejunal flexure, and now I'm injecting barium directly. Rather than having a patient drink barium slowly, I'm injecting the barium, which results in better distension. So this is what is called as barium enteroclysis. So this study is called as barium enteroclysis, where I am now taking a tube. We are taking a tube up to the DJ flexure, and you are injecting the barium, so the distension is better. Understood how to identify? Look for a tube. If there's a tube, it's enteroclysis. If there is no tube, you can see contrast within the stomach also, means patient has drunk the barium. This is BMFT. Both of these are used for the evaluation of small bowel. As we discussed, even though we have these two studies, we don't do them in practice. In practice, we rely on CT enterography because that gives us a 3D perspective, right? So that is what we do in practice, but these are important for the exams. And look at the final image here. This is where you can see these incomplete folds called postrations. So this study here is barium enema. Barium enema shows you this large bowel. The feature of large bowel are these incomplete folds that we call as postrae. So these are the postrae that are incomplete folds. So these are the various barium studies and their names. Now let's start from the esophagus and understand the different GI pathologies. So here I'm showing you two abnormal barium swallows. In the first one, you can see that the esophagus is completely distended with a smooth tapering distally. What is the diagnosis? This is the most commonly asked question. Don't get this wrong. This is achalasia, achalasia cardia, as some people like to call it. So achalasia is essentially a motility disorder. It is a motility disorder wherein the lower esophageal sphincter does not relax. The lower esophageal sphincter is very tightly wound because there is deficiency of the inhibitory neurotransmitters. The inhibitory neurotransmitters VIP and NO are not there. So the lower esophageal sphincter does not relax, and because of that, there's a functional stricture which develops, resulting in this dilated mega esophagus. So that's the pathophysiology there. Now let's further talk about how will you investigate it further. So the investigation of choice for this, because it's a motility disorder, remember, is a manometry. We do a high resolution manometry, which will tell us that there is this increased lower esophageal sphincter pressure. It will also tell us that there is no peristalsis. Because again, understand, for any peristatic wave to proceed, You need something to constrict, which is acetylcholine, and you need something to relax. That's how a wave will go forward. If I don't relax, I will have no peristalsis. So that's what we see in achalasia manometry, that there is no peristalsis because there is no relaxation here. Clear? So this is achalasia. Radiology-wise, you are going to see a smooth tapering. And what do we call this sign? This sign is called as the bird beak sign. So the smooth tapering bird beak is achalasia. Compare it with this particular patient here. Here you can see that there is this irregular sort of a narrowing. There are few outpouchings like diverticulae. Whenever you see such an irregular appearance, this is what is carcinoma. This is CA esophagus. And this irregular appearance is what we call as the rat tail sign. So CA esophagus, irregular rat tail sign. And here the investigation of choice is going to be to do an upper GI endoscopy and take a biopsy to confirm. So this is where the investigation of choice is biopsy. Now, history-wise, please don't rely on weight loss. I've seen students do this mistake. They give you a patient who has history of dysphagia, who has weight loss, and then they give you this appearance. Most of the times in the exam, they give you achalasia. I've seen many students mistake it for CA and mark it otherwise. Very rarely have I seen a question on CA and students marking it as anything. So what you have to remember is achalasia has the highest chance of getting asked. Okay, so if you don't know, mark achalasia. Why will you not rely on weight loss? Because both of them can't eat. Now, if you can't eat, you're going to have weight loss. So both of these are going to have weight loss. Don't rely on that to mark your answer as carcinoma. Is that clear? So this is achalasia versus carcinoma. Looking at three more barium swallows now. Look at this one. Can you see this linear sort of an appearance? This has been called as a pseudotrachea appearance because of the lines. This has been called as a feline esophagus because apparently cats have an esophagus like this. The diagnosis is eosinophilic esophagitis. So eosinophilic esophagitis on biopsy, you're going to see eosinophils in esophagus. So this is what is feline esophagus. Next barium swallow, if I tell you this is a patient who has history of HIV/AIDS. Now tell me your diagnosis. So when you see this diffuse involvement, there are these multiple ulcerations resulting in this diffusely irregular sort of an esophagus. This has been described as a shaggy esophagus. So in a patient with HIV/AIDS, shaggy esophagus, this is Candida. Candida esophagitis, remember, is an AIDS-defining illness. Okay, so Candida is an AIDS-defining illness. Candida oral thrush, not AIDS-defining, but Candida esophagitis is an AIDS-defining illness. All right, so that's what we need to remember here. Look at the next image. We can see that there is this corkscrew-like appearance of the esophagus, multiple spasmodic contractions. This is where you have the presence of tertiary peristatic waves. So here you are having diffuse esophageal spasm. So this is DES or diffuse esophageal spasm, and this appearance is called as corkscrew esophagus. Okay, so remember DES, diffuse esophageal spasm. Moving on to the next pathology. So now I'm going to discuss a bunch of pediatric emergencies for you, all of which very, very important. So this is our first patient. Tell me if you know the diagnosis, tell it in your mind. So what is the diagnosis? I think you have it. It is intussusception. So now let's do the related question of intussusception. What is intussusception? First of all, it is the telescoping of one bowel into the other. Yeah, so that's what is intussusception. The age at which most commonly the patients will present is around 6 to 8 months, because this is the time when you start weaning off a baby of breast milk. You're going to start top feeds. This is also the time around which babies will get the rotavirus vaccine. So this is also one of the adverse effects which may follow rotavirus vaccination. It's a very, very important buzzword for you. Okay, so this is the time when a child is going to present. The child is going to be in a lot of pain. Now, a 6-month-old can't tell you that I'm having pain abdomen. So they're just going to cry a lot, right? So incessant crying, and the mother might tell you that my child has blood-laden stool, also called as red currant jelly stools, right? So they might tell you that there is blood in the stool as red currant jelly stool. Now, two buzzwords for you. Whenever you hear this word red currant jelly stool, if it is painless, then you are going to consider Meckel's diverticulum. But if the child is in a lot of pain, crying incessantly, then you are going to think of intussusception, right? So these are my two DDs for red currant jelly stool. Coming back to intussusception, the most common type is ileocolic, and the significance of weaning comes in here. Whenever you are weaning off a child, or when you are giving these rotavirus vaccines, what happens is at the ileum you have Peyer's patches, right? Your mucosal collections. So these mucosal lymphoid collections are in a hypertrophy. So these Peyer patches hypertrophy, and that is going to act as a lead point leading the ileum into the colon. So ileocolic intussusception is most common. Now, when such a patient presents to you with such a history, the first thing you will do is an ultrasound. So shown here is the ultrasound. What can you observe? You can see that there is one loop of bowel and then there is other. So this is what is intussusception, referred to as various signs. People call it the target sign, donut sign. Some people call it sandwich sign. It looks like a kidney. On kidney also we see outer cortex is hypoechoic, medulla is hypoechoic. So this has also been called as the pseudo-kidney sign. So 4 signs basically telling you that I can see 2 loops of bubbles, one within the other, right? So we did the ultrasound and you saw this. What do you think is the best investigation? The overall best investigation, and I'm going on to calling it the gold standard, means that it is diagnostic as well as therapeutic. And what is that? That is barium enema. So in barium enema, what you're going to do is you're going to push the barium from the perorectal route. Now, suppose there is an intussusception at this site. Wherever the bowel loop has gone inside, this part here is going to present to you like a claw. So this is what we call as the claw sign. Okay. Now, why am I doing this barium? We said that barium is contraindicated in any obstruction. There's also an obstruction. But then I'm not going from the proximal route. I'm coming from the other side. I'm coming from the perorectal route. So I am giving barium now to push the intussusception out. Whatever is coming, I want to push it out from here. So this is where now the bowel loop is going to go out like this. And this pattern is what is called as the coiled spring appearance. So when the intussusception reduces, and it comes out, this is what we call as the coiled spring appearance. Is this clear? So claw sign, coiled spring appearance on barium enema. Now, instead of barium enema, if they give you air enema, saline enema, we can even do those, right? So saline enema is usually given with ultrasound, whereas barium and air are given along with X-ray, right? So that's what is the concept here. Any enema will do the trick. We just need to create the hydrostatic pressure to push it out. Okay, so that's intussusception. Next, pediatric emergency. This is where you have a neonate who's presenting to you with respiratory distress. So the clinical feature is here is neonatal respiratory distress. See the X-ray and tell me what is wrong. We can see here that all of the bowel loops have come inside the thorax. So this is happening on this side. This is the left side. This is happening because the diaphragm here is not well formed. So there is herniation of the bowel loops into the thorax. So the diagnosis is congenital diaphragmatic hernia. Okay, so this is what we call as CDH or congenital diaphragmatic hernia. There are two types to this. You want to remember a word BPL, below poverty line, BPL. So there are two types. The more common type is the Bokdelek hernia. Bokdelek hernia is a posterior defect on the left side. So this is what is our Bokdelek hernia because it's on the left side. The other type is called as the Morgagni type. Morgagni hernia is seen on the right side and is an anterior defect. So if you just remember BPL, everything is sorted. So this is where you have a defect on the left side through which the bowel loops are herniating, whereas in Morgagni, just the liver, because liver is anterior on the right side, just the liver herniates a bit upwards, and this is what presents late in adults, right, as mild discomfort. Whereas Bokdelek is the one which is going to present to you as this neonatal respiratory distress. Okay, so that's what is the one type we are discussing right now. Now, look at this X-ray and understand what's going to happen. My heart was supposed to be on the left side. Because the bowel loops came up, the baby's heart got displaced to the right side. So now the left lung is gone because of the bowel loops and the right lung is being pushed because of the heart. So that is why this baby has pulmonary hypoplasia, and that is the most important prognostic factor. So what I need to do is ensure that the lungs can be inflated as much as possible. So for that, what do you do first? If they ask you what is the next step, what will you do? First, I need to ensure that the child gets some oxygen. The child is in respiratory distress. So the first thing you do is put an ET tube. Next thing you do is you put an NG tube. Very, very important, because NG tube when you put, you will decompress the bowel loops, you'll cause some space for the lung to increase. So that is what you have to do, and eventually the patient will have to be taken for definitive surgical repair. Very, very important question that is repeatedly asked is what will you not do? So what you will not do in this patient is bag and mask ventilation. When we do bag and mask ventilation, I just blow air in the mouth. What happens is the air not just goes into the trachea, it's also going into the esophagus. So now my bowel loops further inflate, which I can't have here. So that is why we will never do bag and mask ventilation. Look at the X-ray again. Can you appreciate that there is one ET tube? This one here is an NG tube. So NG tube not just decompresses, it also confirms your diagnosis. Normally NG tube should go here into the stomach, but here you can see that the NG tube is pointing into the thorax, hence confirming that the stomach has herniated into the thorax. So both of these can be done. Then you are seeing your bowel loops and the heart being displaced. So this is our all questions that are covered from CDH, congenital diaphragmatic hernia. I want you to contrast that with this particular image. Can you see one air fluid level here? And there is no air fluid level in the left diaphragm, below the left diaphragm. That is where I expect stomach's air fluid level to be. So what does this mean? It means that the stomach has now herniated into the thorax. When it does so in the midline, what is this called? This is what we call as hiatal hernia. So this is hiatal hernia, where through the hiatus, the esophagus brings the stomach up into the thorax. Fine. So hiatal hernia, as you know, are two types. The more commoner is the sliding hernia, where the G junction slides up. The other one, which is less common, is the rolling hernia. When the J junction is in place, it's normally the fundus which comes up. Which type do you think this one is? If it's just the junction, will I have an air fluid level? I won't. I will only have the air fluid level if the fundus is up and the G junction is in place. So this hernia in the image is actually our rolling hernia, all right, because I can see the fundus up into the thorax. So they will ask you this image and they won't have to type, but they'll ask you what is the diagnosis, and this is hiatal hernia. All right, so remember when you see a retrocardiac, we describe this as a retrocardiac air fluid level. Behind the heart, we have an air fluid level. Okay, so this is hiatal hernia. Next, we are discussing three emergencies. Let me give you the clinical picture first. Here, the child has presented to you with projectile non-bilious vomiting, whereas the other two cases, the child is presenting to you with bilious vomiting. So that's the clinical history. In the first one, when they say projectile non-bilious vomiting, the first thing that comes to our mind is CHPS. Non-bilious means it's proximal to D2. Yeah. So this is at the level of the pylorus. What is CHPS? Congenital hypertrophic pyloric stenosis. This is where the pylorus muscle is so much thickened that it leads to gastric outlet obstruction. Okay. So this is where the child is going to come to you as soon as the baby feeds. They're going to have non-bilious vomiting. For CHPS, you want to remember investigation of choice is ultrasound. Ultrasound will demonstrate the thickened pyloric muscle and the increased length. If you want to remember the numbers, the length must be more than 16 millimeters and the diameter must be more than 4 millimeters. So you can remember 4 and 4 are 16. So 4 and 16. If I do an X-ray here, you're going to get one dilated loop of stomach here. So this is what is called as a single bubble sign, because the stomach is filled with air and then I have obstruction, so the air can't go distally. On the other hand, what do you see? Here now we can see two bubbles. One bubble is the stomach here, which is distended, and the other bubble is the duodenum, which is distended. So this is what we call as the double bubble sign. And where do we see this? This is what you're going to see in duodenal atresia. There, most commonly, the second part of duodenum is atretic, and that's why the proximal duodenum and stomach become dilated. DO. This is also related to Down's syndrome. Look at the third one, recent FNG question. You can see 1, 2, and 3 bubbles now. So this means that the obstruction is even distal to the duodenum, meaning this is our triple bubble sign indicating jejunal atresia. So this is jejunal atresia. Done. So single bubble, CHPS, double bubble, duodenal atresia, triple bubble, jejunal atresia. Next, talking about this condition wherein you will be given a child who's presenting to you with bilious vomiting. Again, an infant with bilious vomiting, intestinal obstruction. You are doing an upper GI contrast study. Because the child is in obstruction, you won't do barium, but you can use a gastrographin or iohexol as contrast. So we have given this contrast orally. This is the esophagus, this is the stomach, and now what do you see? We see that the bowel is twisting upon its own axis. Can you appreciate this? So this is also referred to as corkscrew sign. Remember corkscrew, diffuse esophageal spasm. Which bacteria has corkscrew motility? Treponema. And now I have corkscrew sign here. And what does that indicate? It indicates that the midgut is twisting on its own axis. So the diagnosis here is midgut volvulus. And midgut volvulus is something that you will frequently see with malrotation. So this is midgut volvulus with malrotation. When you look at the CT scan, again, look at these. These are vessels, mesenteric vessels. And can you see they're twisting on their own axis? So this is what is also referred to as a whirlpool sign, the twisting of the mesenteric vessels. So this is midgut volvulus, malrotation. It's a surgical emergency. For malrotation, you do a surgery that is called as the LAD procedure, right? So that's what you need to know here. Very, very important, almost a certainty that in every exam you get a question on this. You will have a patient who's coming to you with intense pain, abdomen. They will give you buzzwords like the patient having guarding, rigidity, tenderness. So these will be the buzzwords that they give you. They will first ask you, what is the next investigation? So the next investigation or the first investigation that you're going to do is a chest X-ray PA erect view. So chest X-ray PA erect view is what you will do next. This is what it looks like. So this is what frequently they'll give in the exam. Where will you look? Will you look under the left diaphragm or the right diaphragm? We will look under the right diaphragm always, because as we discussed, this is stomach, air, which is normal. So don't look under the left side, always look under the right diaphragm. And when you see that there is air, this indicates that there is free air. When I'm standing and there is free air in the abdomen, it will come up against the diaphragm. So this is what is the diagnosis of perforation peritonitis or pneumoperitoneum. Is this clear? The moment my X-ray shows me perforation or pneumoperitoneum, what are you going to do next? So if the chest X-ray PA erect view is positive, it shows you perforation, this is a surgical emergency, you're going to resuscitate the patient and take the patient up for exploratory laparotomy. So this is a surgical emergency, take the patient up for surgery, you can resuscitate, given the options. Now, few more pointers here. What if the patient is too sick to stand? Sometimes your patient may be too sick to stand, right? Can't even stand up for an erect view. Now, what can you do? Now, you can ask him to turn at least. Which side? You will ask him to turn to left lateral decubitus. Left lateral decubitus means left side is down and the right side is up. It will look something like this. So now when the right side is up, if there is free air, again, I will see it against the liver. Getting it? If I had done a right lateral decubitus, I would have had stomach here. Now, stomach also has air. Outside also there's air. I would have missed it. But on the right side, there's only liver, so I can see this very nicely. So when the patient is too sick to stand, the view you will do is left lateral decubitus. But if they tell you that we are still suspecting a perforation, but the X-ray is normal, what is the most sensitive investigation? So the most sensitive investigation is a CECT, particularly with oral contrast. So we may give IV as well as oral iodinated contrast, because that not just shows the air, it will also show you the exact site of the leakage. All right, you'll see the white contrast spilling from the site of perforation. So that is what you can see here. You're seeing this black air, which is the free air. Now when the patient is supine, CT scan patient is supine, right? So the air is going to come anteriorly. So that's where you got to look at air on a CT. Done. So this is about CCT, the most sensitive investigation. And what I'm showing you here, in a baby, can you figure out this belongs to a neonate? In a neonate, one condition is necrotizing enterocolitis. In necrotizing enterocolitis, the last stage, according to modified Bell's, we call it as 3B, is pneumoperitoneum or perforation. Now, can you ask a neonate to get up and do a chest X-ray PA view? You can't. Can you ask neonate to turn to left side and stay for a while? You can't. Now, in a neonate, the only X-ray I can take is a supine view. And that what I'm going to get is air completely surrounding all of the organs. And this is what is called as a football sign. So another sign of pneumoperitoneum on a supine radiograph is what we call as the football sign. Clear? So this is all about pneumoperitoneum. Chest X-ray PA erect view, look for right air under the diaphragm. If too sick to stand, left lateral decubitus, CT is most sensitive, football sign in neonate. So this is what you need to remember here. So now let's talk about intestinal obstruction. So whenever you get a patient who has abdominal pain, obstipation means failure to pass fecal matter as well as flatus. So when you have complete obstipation, abdominal distension, vomiting, these are all features pointed towards intestinal obstruction. So this is the history that they'll give you. And then either they'll ask you what is the next step, or more commonly what they'll do is they'll give you one of these images and they'll ask you what is the diagnosis, and then they'll ask you the management. Okay. So first of all of these patients of intestinal obstruction are going to undergo conservative management in the form of IV fluids. All of these are going to get an NG tube for decompression, and they're kept nil per oral. So this applies to everybody. Then what we do is we get X-rays done. Normally in practice you will get supine plus erect abdominal X-ray done. If they ask you to choose in between the two, what you will choose is a supine X-ray. So remember the first thing, that the X-ray that you will prefer is supine more than erect X-ray. Both of these have their own applications. A supine X-ray is going to show you the distended bowel loops. Now, what do I call as a distended bowel loop? Normally also bowel loops are going to have air. So what is the difference between a bowel loop which is distended and something which is normally filled with air? It's the diameter. So let's first talk about this. And here you want to remember the rule of 3, 6, 9. A small bowel obstruction or a dilated small bowel loop is anything which is more than 3 centimeter. A large bowel obstruction, it is more than 6 centimeter, and a cecum is dilated when it is more than 9 centimeter. So this is small bowel, large bowel, and cecum that you want to remember 3, 6, 9. It is this diameter beyond which I'm going to call a bowel as obstructed. So that is what supine view shows us. An erect view is going to show you this. Whenever somebody is standing, you know that air will rise up and the fluid is going to go down. So suppose this is a bowel loop which is obstructed and the fluid basically layers out. So this is where you are going to have the air fluid levels. These horizontal levels that you can see here, so many of them, this is what we can only appreciate when somebody is standing. So that is what erect x-rays will show you in cases of obstruction, are these air fluid levels, and these levels we see in cases of small bowel obstruction. Okay, so this is what is the x-ray that you need to remember. So it's supine more than erect x-ray. So now let's jump into the x-ray. So this is the first x-ray that is shown to you. So as you can see these multiple air fluid levels, this is what we refer to as a step ladder sign, and this is what's suggestive of small bowel obstruction. These are not seen in large bowel obstruction. Next, whenever it is small bowel obstruction, the loops are going to be central. So SIRS is small bowel, SIRS is centrally oriented bowel loops. On the other hand, look at this x-ray now. You can see that this loop here is oriented towards the periphery. So a large bowel, because of its anatomy, right? So large bowel obstruction is going to be peripheral loops which are dilated. Small bowel is going to be central loops which are dilated. Then look at the characteristics. Can you see what we studied even in the barium studies? Can you see these complete mucosal folds here? So when we see these complete mucosal folds, that is what is called as valvulae conniventis. And you remember that this is a feature of jejunum. So this tells me that these are the jejunal loops which are dilated and it's small bowel obstruction. The ileal loops tend to be here in the pelvis. So in this case, you can see that it's jejunal loops which are obstructed and not the ileal loops, right? So this is how we can know what loop is actually dilated and where the probable level of obstruction would be. In this case, we can see it's somewhere between jejunum and ileum, right? On the other hand, here in the large bowel, can you all appreciate that there are these incomplete folds? You can also see that this loop is dilated till here and then it stops, meaning there must be a cause of obstruction somewhere at this point. So this is what we call as the transition zone. Plus, can you appreciate these incomplete folds here? So this is what we call as haustrations, and you know that that is a feature of large bowel obstruction. So whenever you see haustrate, it is large bowel. Whenever you see valvulae conniventis, it is small bowel. Yeah. Now let's talk about the theory questions here. The most common cause of small bowel obstruction is adhesion. So these adhesions form due to some sort of prior surgery. So they will give you history of a prior surgery. Whereas large bowel obstruction, the most common cause here is cancer. The most common cancer of the GI tract is the rectum. So see a rectosigmoid junction, if asked to choose rectum more than sigmoid colon, right? So that is what you can also expect. In this particular case, somewhere close to the sigmoid colon, you will be having most likely a mass. Small bowel obstruction, the management is usually conservative. So you will see, wait and watch, unless you have some high risk features, you will wait and watch for 24 hours. There is no point of operating, right? Because why was this caused? This was caused because of a prior surgery. Now if you again do surgery in every case, you are starting a vicious cycle where again the patient might develop small bowel obstruction. So don't want to keep doing that. So it's conservative, you wait. If there are some high risk features or the patient doesn't resolve in 24 hours, then you can go ahead and operate. But the initial management, which is expected of you to know, is conservative. On the other hand, large bowel obstruction, the cause is cancer. You can't tell the patient wait for 24 hours. If your cancer doesn't go away, then we'll operate. No, you can't do that. So this is where you have to operate straight up, right? So this is what is the approach to intestinal obstruction and the relevant points that we need to know about. Now, talking about volvulus. The meaning of volvulus is when one organ is going to twist on its own axis. That is the definition of volvulus. This can happen either in the sigmoid colon or the cecum. So now, what are the two main features to distinguish? There are a lot of differences, which I've also discussed in the main video. But actually, when you look at a radiograph, the two features which are really going to help you are, first, whether you see haustrations or not. Look at the first X-ray. You can see that there are no folds whatsoever. So it is a ahaustral loop. So the first point is whether haustra is there or not. Second X-ray, where we are seeing the same thing here. Now you can appreciate that in this particular dilated bowel loop, you can also see the haustrations. So this is where the haustrae are present. That's the first thing you observe. The second thing you have to observe is how many loops can you see. In this particular X-ray, you can see 1 and 2. 2 loops of bowel which are dilated, whereas in this, you can see one particular loop of bowel which is dilated. So the second point we observed is whether 2 loops or 1 loop. Now what we have to see? Few signs. So I think all of you can appreciate here, all of you very well know this is what we refer to as the coffee bean appearance, where it indeed looks like a coffee bean, also being referred to as a bent tube sign. So all in all, ahaustral, 2 loops, coffee bean, bent tube, all of these are findings of sigmoid volvulus. So this is sigmoid volvulus. You will be mentioned a few risk factors like an elderly patient who's had chronic constipation. How do we manage sigmoid volvulus? We are going to put a flatus tube. So either they will write flatus tube insertion or they may write endoscopic detorsion. The point remains you don't need to operate this patient. You put in a tube or an endoscope and the sigmoid colon is deloaded or unloaded and you will be able to detort it. On the other hand, when you see a haustral single loop, looks like a C. Yeah, so this is what has been called as the C sign, C for cecal volvulus. So this is cecal volvulus. Here you would be given a few risk factors like pregnancy. There might have been some pelvic surgery which has been performed here. How do you manage this? This patient needs to be operated. Okay, so this is what we need to remember as far as the holistic approach of sigmoid versus cecal volvulus is concerned. The other features like where it originates from, where the apex is not reliable, because when a bowel loop becomes distended to a certain limit, after that the position can change, right? So that's something which is not reliable. Cecal volvulus is considered to be a clockwise twisting, C4C, but a sigmoid is anti-clockwise. Again, something not very reliable because you can't really observe that on the X-ray, right? That's more of a theoretical point. So in practice, if you observe these 2 points, you are sorted. Okay, so now let's talk about a few important barium signs. Look at the first image here. So this is where you can see, first of all, these are the jejunal loops. You can say that from the outline, the feathery outline that we are observing. These are the terminal ileal loops. And now you can see this is the place where the ileum is supposed to join the cecum. So this is our terminal ileal loop. At this point, you can see that there is a stricture, there is a narrowing. This has been called as the string sign because the ileum looks like a string. So this is the string sign. Now, just this ileal stricture can be seen in a variety of conditions. The 2 most common causes being TB and Crohn's disease. TB can involve any part of the ileum, but the most common part you want to remember is the junction. The most common area is ileocecal junction. This is associated with pulled up cecum. In the chronic stages of TB, you're going to have fibrosis and contractures, and the cecum tends to get pulled up. So that is what we observe in TB, pulled up cecum, right? So that's what you need to know. In addition, the most reliable finding is not barium. We already discussed that barium is not something that we actually do in practice. In practice, you do a CT enterography. In a CT scan, when you see an ileocecal junction stricture, along with necrotic lymph nodes. It's these necrotic lymph nodes which are the hallmark of tuberculosis. Whereas Crohn's disease is where the terminal ileum is indeed the most common part. It tends to spare the ileocecal junction. It's the terminal ileum. And this sign in terms of Crohn's disease is what we refer to as string sign of Candor. So when I say string sign of Candor, it is C for Crohn's, K and K. That's what you want to remember. Crohn's disease, when we look at the CT, the lymph nodes are going to be non-necrotic. You're going to see non-necrotic lymph nodes. So that is how we actually distinguish on the basis of a CT scan. So this is what you need to know about string sign. Then when we look at this barium enema here, you can see that the complete colon is missing the hostrate, which was its hallmark. So when you see this colon appearance where it has lot the hostration, this is what is called as the lead pipe colon appearance, and this is the hallmark of ulcerative colitis. You know, ulcerative colitis starts from the rectum, the most common part is rectum, and then spreads in a continuous fashion to involve the entire colon. So that's what you can see here. When you see this irregular sort of an appearance, this is what has been called as the apple core appearance, and this is what represents CA colon. On this particular barium enema, you can see how there are these outpouchings of contrast. These are diverticulae. True or false? These are false diverticulae. Remember, all diverticulae are false except Meckel's diverticulum. Meckel's is the only true congenital diverticulum you need to know about, right? So this is what we call as sigmoid diverticulosis. This is what is going to present as a painless lower GI bleed. So this is diverticulosis, which is painless lower GI bleed. You do the barium, and this particular sign is what is called as sawtooth sign. This is asked in FMG exams a lot, okay? So this is the sawtooth sign. Now, potential complication of diverticulosis is diverticulitis. One of these diverticulae can become inflamed. The complication is it can then rupture to cause peritonitis. It may form fistula with the bladder and adjacent organs. So diverticulitis is a problem. Now, how will I know it is diverticulitis? You'll have symptoms of itis. So what are the symptoms? You will have pain in the left lower quadrant. You may have fever. You may have leukocytosis. So you'll be getting these symptoms of inflammation. Now, what is very important is you will never ever perform barium in diverticulitis. Barium becomes contraindicated because then if these diverticulae rupture, they're going to lead to peritonitis further. We're never going to give barium in this particular patient. That's very important. So now what do I do? How do I make this diagnosis? So here the investigation of choice, remember, is going to be a CECT. So CECT is going to be the investigation of choice for diverticulitis. In surgery, you will also study the Hinchey classification, right, of diverticulitis. So this is about these important conditions. Going on to this particular mass lesion in the liver. What is the diagnosis? 3 images, 1 diagnosis. What do you think? This indeed is hydatid cyst. So hydatid cyst, remember, is caused by Echinococcus granulosus, most commonly. Echinococcus, what is the primary host? The primary host is a dog. That's why it's called as a dog tapeworm. Who is the secondary host? That is a sheep. Humans become accidental or dead-end hosts. So frequently they give you history of dog being a pet in this particular history, right? So that is what is about hydatid cyst. Now the radiological appearance. Before we understand the radiological appearance, we just need to know how it evolves, right? So basically, hydatid cyst has 3 layers. Okay, so that's the first layer. Then you have a second layer, and then we have a third layer. So now we have 3 layers here. The first layer is what we call as the endocyst. The layer in blue is the ectocyst, and the outermost layer is the pericyst. Okay, the pericyst is actually not a layer of hydatid. It is the connective tissue of the liver, right? Because liver is the most common organ, or any other organ. The connective tissue is what forms the pericyst. Endocyst is what is the reproductive layer. This endocyst is what is going to form the daughter cyst inside, and that is what is going to then degenerate. Ectocyst is nothing but a lamellar membrane. All right, so this is not going to reproduce or do anything. It is just the lamella around it. All right, so now how does the hydatid evolve? As soon as you have a hydatid cyst, first you are just going to see the 2 layers, and then you have the pericyst. Now the endocyst will show us the daughter cyst, and that is where you see this kind of an appearance, where within the cyst you have multiple daughter cysts, and this appearance is what we refer to as the honeycomb sign. Now, once the reproduction is done, the function of endocyst is apparently finished. So now what is it going to do? It is going to die. It is going to degenerate. So now the endocyst degenerates and it floats within the cyst. So can you appreciate here that we can also see, can you see this? That this is the ectocyst, and you can also see one more layer, which is the pericyst, and the endocyst is floating inside. So the innermost layer is floating inside, and this appearance is what is very famous water lily sign, right? So now it has degenerated. This is what we refer to as the transitional stage. This was the active stage, right? So this is active, and then you have the transitional stage. Eventually, this is going to become hydatid dust or hydatid sand. It settles, and then eventually the final inactive stage is when it becomes completely calcified. We know from our thumb rules, whenever I want to see calcification, what is the best investigation? What is this? It is a CT scan. When we see the bone is white, it's a CT. Can you tell me whether this is NCCT or CCT? How will you say? You will look in front of the vessel. You will look at the vessel in front of the vertebra. So this here is the aorta, and you can see that the aorta has no contrast. So this is a non-contrast CT scan. So this is an NCCT. When you see this white colored lesion in the liver, which is on the right side, this is a calcified hydatid cyst. Yeah. So this is calcified hydatid cyst, and this is the end stage of this. All right. So this is an inactive hydatid. You don't need to treat it. This is the final end stage. So this is what you need to know about hydatid. These are the 3 stages, 3 appearances that they can ask you. Liver indeed is the most common site. The second most common site is the lung. One thing that I can tell you about lung, you also see in the lung a similar appearance, which is called as the water lily sign, where the membrane will crumble down. The only difference in lung is it never calcifies. Like how in liver we saw the end stages being calcified, a lung hydatid does not. It's just how it is. Okay, so that is what you need to remember in general about hydatid. Okay, next let's look at gallbladder. We already discussed that anything to do with gallbladder, the investigation of choice is ultrasound. Gallbladder means ultrasound. So I'm now going to show you 5 pathologies of the gallbladder. All of these are ultrasounds. You have to tell me what is the diagnosis. So look at the first one here. What is it? What did we study? This is the gallbladder. You can see there is a hyperechoic stone, and behind it you can see that there is this shadowing. So this is what we refer to as posterior acoustic shadowing, making our diagnosis very simple as gallstones. So for gallstones, remember investigation of choice is ultrasound. They are not radiopaque stones. They are made up of cholesterol pigment. So what we are going to rely on is the shadowing on ultrasound. Okay. Now, just gallstones, remember, most of the time they're going to be asymptomatic. You can either have some biliary colic, which is pain, or you may have inflammation of the gallbladder, which we refer to as acute cholecystitis. So acute cholecystitis, remember, the patient is now going to come to you with, again, itis features. So you'll have fever, right upper quadrant pain. I'm sure all of you know the Murphy's sign, where if you press on the ninth costal cartilage, the patient winces in pain. So all of these are the clinical features. Again, the investigation of choice remains ultrasound, wherein what you will observe is usually there's an associated stone. Most of the cholecystitis are calculous cholecystitis. So you can see there is a stone obstructing the neck of the gallbladder. You can see the shadowing here. In addition, in cholecystitis, what you see is the wall, right? So in cholecystitis, compare it with uncomplicated gallstone. This is the thin wall which you can't really see. Whereas here, you can see that the wall has become thickened, and not just that, you can see there is some layer of fluid within it. So this is what is a thickened wall. The exact number, you may not remember, it's fine, but it's more than 3 millimeter. So we are actually looking at wall thickening here. So that is the hallmark of acute cholecystitis. Another way to diagnose acute cholecystitis is HIDA scan. So you can also use HIDA. They say theoretically HIDA scan is actually most accurate. It has highest accuracy for picking up acute cholecystitis, but we won't do it in practice because HIDA scan uses technetium. Technetium means gamma rays. It means a lot of radiation. When I can easily pick it up on ultrasound, why do I need to do a HIDA scan for this? So it's theoretically most accurate, but not done in practice. So don't get confused. If you get both options, you're going to mark ultrasound. That's what you do in practice. Okay. So HIDA scan, actually, just to tell you the concept, is just like bilirubin. It is excreted from the liver into the biliary duct and the gallbladder, and then it comes into the intestine. So normally you will see all of these structures like a bubble. What happens in acute cholecystitis? That this gallbladder is so inflamed and so obstructed that there is no HIDA which can enter the gallbladder. So what you see in HIDA scan is actually non-visualization of the gallbladder. So when you don't see the gallbladder, it is something which is abnormal, and that is when you suspect acute cholecystitis, right? So this is about acute cholecystitis. Look at the next image. What do you think is the diagnosis? There is a hyperechoic lesion attached to the wall. Is this a stone? This is not a stone because there is no shadowing. So this is what is a gallbladder polyp. This is a GB polyp. There is no associated shadowing, and it is non-dependent. It is hanging from the wall. The importance of a GB polyp is any polyp which is more than 1 centimeter, it must be operated because there may be underlying malignancy. So less than 1 centimeter polyp, nothing, reassure. More than 1 centimeter, prophylactic cholecystectomy is performed here. Okay, so that's what is important. Look at the next image. This is where you see these small comet tails here coming from the wall. So this is what is called as the comet tail sign. And this is seen in adenomyomatosis. Adenomyomatosis is a condition wherein within the wall of the gallbladder, you have these diverticulae or outpouchings which form, and they tend to have these small cholesterol crystals. So these cholesterol crystals give this sort of a streaking here, which is a comet tail. So that is adenomyomatosis. The counterpart of this pathologically is what you study as strawberry gallbladder. I'm sure you've studied that in path. So that's strawberry gallbladder, which is cholesterolosis, right? So you want to remember both of these go hand in hand. The clinical radiological diagnosis is adenomyomatosis. The next image has been asked in the recent exam. So what you see here is the gallbladder folded upon itself. So this is a gallbladder just folded upon itself. It looks like it's wearing a cap. So this appearance is called as a Phrygian cap. Nothing needs to be done. It's a normal anatomical variant, right? So these are your 5 spotters from gallbladder that we need to know about.